On this slide, you see the continuation of the running suture. Some responsibilities of the ST in peripheral vascular is to ensure the field is free of potential instrumentation that can catch the suture and cause a snag, and to provide irrigation on the surgeon's hands when they are tying the suture to promote easier manipulation of the suture. One quick method to protecting the suture from the instrument-laden field is to lay an unfolded blue towel across all the instruments, including the self-retainer handles, so the suture thread does not become entangled. And a quick route to irrigating the surgeon's hands is to have your asepto filled with your heparinized saline in your hand so that you can squirt their fingertips when they begin to tie their knots. I added this slide to the collection so you don't have it today, but what you see here is an image of the iliac artery, the iliac vein down here, the obturator nerve, and the lumbosacral trunk here. Way down deep. And they are being retracted by little rubber cords. These cords are called vessel loops, and they come in a variety of colors and widths. Sometimes surgeons will prefer a specific type, and sometimes surgeons want a variety of colors so they can use the colors to identify the structures. These come in packages of 2, are counted by the scrub and circulator, and are gently retracted on a vessel, or they're occasionally used to occlude a vessel. These are passed based on surgeon preference. Some like it like a free tie, some like it on a pass, and some like it in the tips of a DeBakey, which you keep pinched together for them during the pass. The latter is my personal experience, where we pinched it together in the DeBakey and then passed it to the surgeon. After passing the vessel loop, you'll need a mosquito clamp to tag it. You'll also have vein retractors on your field, which you can see on page 267 in your instrument book. Vessel retraction is necessary due to the meticulous dissection required in these procedures. Every vessel is connected to soft tissue on every square millimeter of it. So that soft tissue has to be dissected off before the vessel can be opened or repaired. Once a portion of vessel is free of soft tissue attachments, it's helpful to have a gentle retractor to work around it circumferentially, because remember, all vessels have lumens. Another new supply in this specialty is the Rumel tourniquet. First, I want you to get your instrument book out and go to page 244. Once you're there, continue watching this video. Before you can use the instrument pictured, you must have a section of rubber catheter, usually a Red Robinson, which will be cut on the sterile field by you to the surgeon's preferred length. In my experience, that length was approximately 2.5 inches, but know that that is simply a preference. This is supposed to signify the red rubber. The next step in the preparation of this instrument is to slide the cut portion of the rubber catheter over the tip of the Rumel tourniquet hook. The instrument is now prepared for use. This instrument will be used during the case to provide retraction and be available for emergency vessel occlusion if needed. During the procedure, the main vessel in the operation will be identified and dissected free, at which point the surgeon will ask for an umbilical tape. You see on your slide that there's a package of umbilical tapes here. There are 2 tapes in this package, and you must keep track of both of them. Pass the tape to the surgeon, just like a free tie, followed immediately by the Rumel tourniquet. The surgeon will encircle the vessel with the tape, snag the 2 tails with the Rumel, as seen in image A, and then they'll advance the rubber catheter down the instrument and onto the tails, and then the tails will be clamped with a Kelly, which is in image B, but the instrument is already out of the picture. It will remain that way for the majority of most cases, but in the event they need to emergently occlude a vessel, they can do so with this supply by pulling tightly on the umbilical tape right here and securing the Kelly immediately above the catheter as seen in image C. This technique is more effective than tightening a vessel loop and quicker than applying a clamp. You will particularly see this during situations of stent placements, which we'll talk about in a few slides. Next up are Fogarty catheters. also called embolectomy catheters. Remember from your terminology what a thrombus is and why we don't want one in a vessel lumen. These catheters are specifically designed with a balloon at the end to be inserted into an arteriotomy. What's that again? Advance beyond down the known thrombus, inflate the balloon, and carefully draw the catheter out of the vessel, pulling the thrombus out with it. The length, diameter, and balloon size of these catheters will vary and will be selected based on the need. You must have a tuberculin syringe ready so that you can test the balloon before passing it to the surgeon. When I was new, it was hard to understand why these are called embolectomy catheters, but they're used on thrombi, until I realized that the catheter is preventing the embolus from occurring, which would be even worse than just a thrombus. Review your med terms, embolus and thrombus. One moves and one is stationary. Know that the incidence of a thrombus is an emergent procedure because it is likely preventing blood flow to an extremity. This is often referred to as a cold leg or a cold arm, thereby making it a limb emergency case. This slide is about shunts and stents. Shunts are used to allow minimal blood flow through a vessel while it is otherwise occluded. This is particularly evident during carotid procedures. Shunts are made out of plastic and are secured in the vessel either by balloons or silk ties. Because you understand circulation, you know that when a vessel is occluded during surgery, the structures beyond the vessel are not receiving their blood supply. Well, the carotid arteries provide the majority of the blood supply to the brain. And remember from earlier when I said the brain requires 20% of our body's supply of oxygen? That's a lot. And so when the carotid is occluded during a carotid endarterectomy, sometimes the brain says, "No way, Jose, I'm going to have a stroke." And the surgical team has to insert a temporary shunt to allow a little bit of blood to get through the vessel, but not so much that we can't keep working. This is exactly what I was referring to when I discussed the use of the Roumel tourniquet earlier. Usually, shunts are kept in the room, not opened, so they are easily found in an emergency, because in the incidence of strokes, time is of the essence. Stents, on the other hand, are permanent. Stents are small metal implants designed to fit against an arterial wall. They can be made of stainless steel, titanium, or nitinol, and they are kind of like implanting a stent in a ureter in GU. The only differences include an arteriotomy must be made first, and the vessel needs to be secure in the event of hemorrhage. So think vessel loops and vessel clamps at the ready. Otherwise, a guide wire will go up the vessel. This is either going to be in the arm or the leg. Fluoro will track the guide wire as it travels. Then usually a plastic stent with radiopaque markers will be advanced to measure the specific length of stent needed. And then finally, the stent will advance over the guide wire into place to reinforce the arterial wall, particularly in the area of a known aneurysm. Some new on the scene drugs in peripheral vascular include heparin and thrombin. First, we'll talk about heparin and heparinized saline. This medication is used to anticoagulate the blood tissues in the body to prevent a thrombus from forming, which thereby reduces the risk of an embolus. There are basically two methods to this practice. First is the systemic heparin administration. This will be done by the anesthesia provider. Usually, the surgeon indicates the appropriate time to heparinize the patient, and it's during dissection and well before the occlusion of any vessels. After the goal of the procedure has been accomplished and it's time to close, the surgeon will ask for the systemic heparin to be reversed. Systemic heparin is reversed by the anesthesia provider with protamine sulfate. On your field, you will likely have heparinized saline. You will use this solution as your irrigation unless otherwise indicated, because again, we want to prevent thrombi formation. When the systemic heparin is being reversed, it's not uncommon at all for the patient to require coagulation materials to help them from bleeding too much post-op. These supplies will be made of collagen or fibrin products and are more commonly known as gel foam, Surgicel, and Fibrillar. They may occasionally request topical thrombin, which usually comes as a sterile spray. It is very important to remember that thrombin is never, ever, ever injected into a vessel or administered through an IV. If present in the vessels, it will act as a fat embolus, and it is fatal. The surgeon will select a particular method for coagulation and apply it usually at the anastomosis site. Then they will wait a few moments for it to take effect. Once the field appears to be relatively dry, with no major leaking, the closure will begin.